So hello, this is KHURRAM and you're watching Optometry with KHURRAM. And in the last lecture we have discussed about, the last lecture was our first lecture on amblyopia. And in the last lecture we have discussed about the definition of amblyopia, the onset of amblyopia, the etiology of amblyopia, and the pathophysiology of the amblyopia, right? And in the specific video, in this video, we are going to learn about the different types of amblyopia. Like we know very well that we have so many types in terms of amblyopia. Like we have strabismic amblyopia, we have ametropic amblyopia, we have anisometropic amblyopia, we have meridional amblyopia, we have light deprivation amblyopia, we have form deprivation amblyopia, we have visual deprivation amblyopia, and so on. We have so many types in amblyopia. But in this specific video, in this today's video, we will learn about the most important and most common, you can say, type of amblyopia, which is called the strabismic amblyopia, right? So I have the colorful thing on my whiteboard today, and the first we will learn about the strabismic amblyopia, right? So all the writings is about the strabismic amblyopia. We will learn every single inch, every single millimeter about the strabismic amblyopia, right? So the first point on my whiteboard is that the strabismic amblyopia is the most common type of amblyopia. You know very well that, as I have already told you, that we have so many types in amblyopia, right? I'm not going to repeat again. In all these types, the strabismic amblyopia is most common. So what is strabismic amblyopia actually? You know very well that the squint, the deviation is called strabismus, right? So strabismic amblyopia, if your one eye or the two eyes are deviated, this is called strabismus, right? The deviation. So to learn about the deviation, first you have to learn about, you must have to learn about the primary position of the eyes. So if your both eyes are in the center ahead position, straight ahead position, in the center, exactly at the center, that is called the primary position of the eyes. But if one eye is in inward direction, like in esotropia, or outward direction like in exotropia, or upper direction called hypertropia, or in downward direction called hypotropia, so that is called the strabismus, that is called the deviation, that is called the squint, right? So this type of amblyopia, which is called strabismic amblyopia, is connected with the squint, is connected with the deviation, it's connected with the strabismus. So that is why it is called the strabismic amblyopia. The amblyopia due to the deviation, the amblyopia due to the squint, the amblyopia due to the deviation, right? So the first point was the most common type of amblyopia. So the strabismic amblyopia is most common type of amblyopia. This is our first point. And the second one, this is important point, the second line saying that the brain ignores the visual input from the misaligned eye. Remember that what he is saying, that the brain will ignore the visual input from the disaligned eye. Remember that every relationship is a two-way relationship, right? How that if you will ignore your partner, he or she will ignore you, right? If you are loving someone, the love will return towards you, right? And if you are ignoring someone, that he will ignore you. This is a formal example, right? I'm nothing to do with that things. So he's saying that the brain will ignore the visual input from the misaligned eye, right? So when you know very well that your two eyes are strongly connected with the brain, actually your whole body, the anatomy of the whole body is actually connected with the central nervous system. Your whole body is controlled by the central nervous system, by your brain, right? So your two eyes are also controlled by the brain, by the central nervous system. But the brain is controlling two eyes when the eyes are central ahead, when the eyes are straight ahead, when the eyes are aligned, when the eyes are in primary position, right? But if one of the eye is not aligned, like it is going inward, it is going outward, it is going upward, or it is going downward, then the brain will ignore that eye. The brain will not going to give any stimulus to that eye, right? If the eye is deviated, right? So again we will write the second point, that the brain will ignore the visual input from the misaligned eye. If your eye is misaligned, if your eye is not straight, then your brain will start to ignore that eye, and that can lead your eye towards amblyopia, towards lazy eye, right? So if you want to prevent from amblyopia, your both eyes have to straight ahead, your both eyes have to in primary position, right? So I hope you understand the second point. Now the third point is actually important as well. When the visual system is completely formed, like in adult, the patient will observe diplopia. The second point is saying that if your patient is adult, right, it is the age of the patient is more than 20 or 25, and there is a deviation in his or her eye in adulthood, right? So that patient will observe the diplopia, the double vision. Why? Because if one eye is straight ahead and one eye is isotropic, the disalignment in one eye, so the fovea of the straight eye is receiving the image on the fovea, but in this case, in deviating eye, the image is not forming on the fovea, but the image is forming on the paraxial retina or other part of the retina. So the fovea in misaligned eye, the fovea is not receiving the proper image, so your brain will go ignore that eye, right? So in this case, the patient will face the diplopia in adulthood. Why? Because in adulthood, the whole visual system is completely formed, the whole visual system is completed, right, in adulthood. Again, I'm repeating this point, this is important point, you have to keep it in mind, you have to be very careful while you are listening to me this point. What? That if the patient is adult, right, his age is more than 20 or more than 30 years of age, and if that patient is adult and his eye or her eye is deviated, then he or she will face diplopia, right? He or she will face double vision. But I'm going to compare this age group to the another age group, and that is the developmental age, the critical developmental age. If your visual system is not developed properly, if you are in that age, like if you are in infancy or 1 or 2 years of age group, and if your the visual system is not developed properly. And what is visual system actually? First you must know about about the visual system, I'm sorry. And what is visual system? Visual system is actually you know very well that the light is will pass through, first of all will pass through the cornea, then it will pass through the crystalline lens, then vitreous, then it will hit the retina, right? And from the retina, the whole action potential will move towards the optic nerve, right? And from optic nerve, it will go toward the optic chiasma, then optic chiasma towards optic tract, and from optic tract it will go towards the lateral geniculate body, and then finally it will go towards the brain in the occipital lobe. And which part of the occipital lobe? The visual cortex of the occipital lobe. This whole pathway is called the visual system, right? And again I'm repeating, in adult, the adult patient will face diplopia if the eye is deviated. But if the patient is in the critical age, if the patient is in the critical age of developing or the development, then the brain will capable to avoid diplopia. Remember, these are two things. This patient is adult, this patient is in the developmental stage. So that patient which is adult, his visual system is completed, his visual system has completed all the developing stages, right? So the adult will face the diplopia. But this patient which is in the developing stage, the visual system is not completed yet, that patient will not observe any diplopia. Remember, this is important point. The patient which is in the developing stage, he will not face any diplopia, his brain will prevent diplopia, his brain will overcome the diplopia. And how? By inhibiting the activation of the retinocortical pathway. So in childhood, or you can say in that critical age of developing, if the patient is in the developing age, the visual system is not completed yet. So in that typical age, in that critical age, the patient will not face any diplopia. But in that specific age, there would be inhibition of the retinocortical pathway. And what is retinocortical pathway? The retinocortical pathway is the same pathway as I have told earlier, from retina to optic nerve to chiasma to tract to lateral geniculate body and to the occipital lobe or the visual cortex, right? So again, I'm repeating over and over again because this is important point. Adult will face diplopia. Why? Because his or her cortico-retinal or retinocortical pathway is totally completed, right? The whole visual system is completed in adult, right? But in developing stages, right, the patient's visual system is not completed, is not accomplished yet, so he will not face any diplopia, but the inhibition will start in the retinocortical pathway. So that inhibition will lead towards the amblyopia. And now we will learn about the fourth point, and the fourth point is, if the amblyopia is moderate, he is saying that in moderate strabismic amblyopia, the cortical cellular column remains structured. What does it mean? He is saying that if the strabismus is moderate, there is no any severe strabismus, and there is no any severe strabismic amblyopia. In in the moderate strabismic amblyopia, your cortical cellular column remains structured. What does it mean? Cortical cellular. What is cortical cellular column? I have written in the black marker the cortical cellular column. So the cortical cellular column is the same visual pathway, right? The cells in the visual pathway, that connections, right? So if the strabismic amblyopia is moderate, then your cortical cellular column remains structured. It will be fine, right? So there is no any harm if the amblyopia is moderate. It needs treatment, but is not that dangerous, right? Your whole visual system or cortical cellular column will be structured, will remain safe, but it needs an urgent diagnosis, a rapid diagnosis and rapid treatment as well, right? But in deep amblyopia, alteration will occurs in the column, right? If your amblyopia is deep, if your amblyopia is severe, if your strabismus is severe, or if your strabismic amblyopia is very severe, then alteration will be there in that cortico or cortical cellular column. So your visual pathway will be affected, and once your visual pathway will be affected, then amblyopia will be there, and amblyopia will get more and more in that cases, right? And now the fifth point, and the fifth point is saying that strabismus causes changes in or loss of connectivity to the retinocortical pathway. The same thing, that if strabismus is there, if disalignment is there, that disalignment or that deviation in the eyes can cause loss of connectivity between the retinocortical cells. What is retinocortical cells? From retina to visual cortex, that connection, these connection of the cells between these retina and the central nervous system from the occipital lobe, right? So this is the connection, this is the visual system. So if strabismus is there, so the connection between the cells will get disturbed, right? So due to that disturbance in the connectivity of the retinocortical pathway, the disturbance will occur, and in which way? In different visual tasks will get disturbed. And what are these visual tasks? Like visual acuity. So if your eye is deviated, if strabismus is there, so your visual system will get disturbed, and when your visual system will get disturbed, then your visual acuity will be lost. Your visual acuity will be progressively and slowly will get lost, right? So this is the first sign. And next one is, you will lose your vernier visual acuity. So what is vernier visual acuity? Vernier visual acuity is actually the specific type of visual acuity. In vernier visual acuity, there is a smallest minute disalignment. You will observe the smallest minute disalignment between the lines, right? So the vernier visual acuity is most accurate than the visual acuity, normal visual acuity, right? So this is what you will also lose the minute kind of sort of visual acuity, which is called the vernier visual acuity, right? And you will also lose the crowding. What is crowding? Remember that if you are observing a Snellen chart, and you know very well that Snellen chart is not crowding, right? So the visual acuity of a amblyopic patient is more in Snellen chart. If your amblyopic patient is facing a Snellen chart, his or her visual acuity will be more, right? But the same patient, if the same patient is sitting in front of the crowding charts, like in ETDRS charts, like in logmar charts, you know very well that in ETDRS or in logmar we have a crowding phenomena there. So in the first line we have 5 letter, in the second line we have 5 letter, 5 5 5, right? So we have the same letters in every line. So those types of charts are called crowding charts, right? So the visual acuity of a amblyopic patient will be worst in crowding. And now the sixth point is saying that in strabismus there is no binocular facility which cause suppression, right? You know very well that if your one eye is straight, one eye is disaligned, there is no any binocular facility. You are not enjoying the binocular single vision. There is diplopia. So that can cause suppression. In which eye? In the deviating eye. So your deviating eye is start feeling the suppression, right? So this is called suppression, and thus it is suppression that leads to amblyopia in strabismus. So that suppression can lead towards amblyopia in the strabismic patient. So first you are strabismic, and when you are strabismic you will get suppression, and that suppression can lead towards the amblyopia, right? So I hope this is clear as well. So the seventh point is in strabismus, different stimuli like normal image fusion, binocular vision, stereopsis, and posture stability, you will lose these stimuli. If you are strabismic, then you will lose the different stimuli like the normal image fusion. You will lose the normal image fusion. There would be no any fusion. There would be diplopia. So your one eye, like you have two eyes, then you have two retina number 1 and retina number 2. So if you got two eyes, you got two retinae, right? And if you got two retinae, you got two different images, actually two same images, and those images will get fused. But your both eyes are not aligned. Your one eye is straight and one eye is disaligned, right? So when your one eye is disaligned, then you will not enjoy the fusion, right? So you will not get fusion, you will not get binocular vision, obviously you will not get stereopsis, and there you will feel, or you will feel also the posture instability, right? You can feel the abnormal head postures as well. And now our last point is the contrast sensitivity is less defected in strabismic amblyopia. This is very important point. Remember that in strabismic amblyopia, the contrast sensitivity will be preserved. There is no any effect on contrast sensitivity, right? If the patient is of, you can say, the strabismic amblyopic, then his or her contrast sensitivity is not affected, right? The contrast sensitivity will be affected in anisometropic amblyopia, right? So we will observe in strabismic amblyopia we have major impact, we have major effect on visual acuity and binocular vision. So in contrast, so in strabismic amblyopia, the contrast sensitivity is preserved. There is no effect on contrast sensitivity, but visual acuity, vernier visual acuity, and binocular vision will be slowly and progressively will be lost. And now we will learn about the different clinical features in the strabismic amblyopia. So the strabismic amblyopia will face the poor depth perception. Remember that the strabismic amblyopia will face the poor depth perception. He will unable to observe the things properly, right? The depth of the object, the length of the object, right, and the width of the object, right? So there would be a poor depth perception. And the second one is called, he will feel difficulty in catching and throwing the things, right? If you throw a ball towards an amblyopic patient or the strabismic amblyopia patient, then he will feel difficult to catch that object, right, or throw that object. And that third one is called the clumsiness. He will there would be a laziness sort of things in that patient, right? So next one is squinting and shutting of the eyes. obviously he is a squinted patient, so there will be shutting of the eyes, right? Half shutting of the eyes or squinting of the eyes is there in the strabismic amblyopic patient. And next one is head tilt, or you can say the abnormal head postures. He could be his or her head posture could be like this, or could be like this. He will try to overcome that deviation with the head posture, right? So there could be a head tilt or head move or abnormal head postures in the strabismic amblyopic patient. And the last one is called the eye strain or fatigue. Obviously, when one eye is straight ahead and one eye is tilted, he will try uh, to fuse the things, he will try to fuse the objects, and in that try, right, he will feel fatigue or he will feel tiredness in the eyes. So finally, we are going to learn about the management or treatment in strabismic amblyopia. First of all, you must have knowledge that how we will diagnose the amblyopic patient. Remember that the diagnosis is that if you see that there is no any structural deformity, there is no any structural abnormality in the patient's eye, right? There is no any structural deformity. Cornea is fine, lens is fine, retina is fine, you have dilated the fundus, you have observed the whole retina, the whole fundus, there is no any abnormality, there is no any abnormality in the visual system, all the things are clear, right? And then you will put the pinhole before the patient's eye. You will close one eye, you will occlude one eye, and you will put the pinhole. And if with the pinhole the patient can read the whole chart, it means there is no any amblyopia, right? And you will repeat the same thing with the fellow eye. But if you close your one eye, patient's eye, and you put a pinhole before the patient's eye, and after putting the pinhole, there is no improvement in the eye, right? If patient is not reading the last two lines or last three lines or last four lines, then it means the patient is amblyopic. But remember, if there is no any structural abnormality, if there is no any abnormality in the visual system, then you are after pinhole the visual acuity is not improving, that patient is amblyopic patient, number one. And number two, what is the trick to diagnose the amblyopic patient? You will record the visual acuity of the amblyopic patient on two different charts. Chart number one is Snellen chart, and chart number two is the crowding charts, the ETDRS or logmar, right? So why? On Snellen chart, you will observe that when a amblyopic patient will read the lines on Snellen chart, his visual acuity somehow will better, right? But if that patient is sitting before the logmar chart or ETDRS chart or crowding charts, actually he will feel difficulties on crowding, right? The amblyopic patient will always feel difficulties to read crowding charts. This is the clue, this is the point where you will diagnose the amblyopic patient. So these are two different things to diagnose the amblyopia. So we have discussed that how we can diagnose the amblyopic patient, and now let's move towards the visual acuity. So if your patient is so small, if your patient is a baby, then how you will record the visual acuity? You will close his one eye and you will give a target and you will move your target. If your patient is fixating your object, then it means that visual acuity is fine in that eye. But if you close this eye and you give target and you're moving your target, and if your patient is not fixating properly that object, so it means that there is something wrong in that eye, in the concerned eye, right? So now we will, if your age of the patient is more than you can say 2 years, 3 years, 4 years, 7 years, for example, if the age of the patient is less than 15 years, so remember that, first of all, remember that you in amblyopia, you need an early diagnosis. I'm writing here to make you remember, early diagnosis is very, 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 very important in amblyopia. Early diagnosis, right? As I have told you that the lesser the age of the patient, the lethal will be the amblyopia. Remember that. Remember that if your amblyopia is diagnosing in the 18 years of age, it does not mean that amblyopia is started at 18 years of age. No, right? The amblyopia will always start at the newly born, at age of 1 year, at age of 2 years. This is the critical, the developing age, right? The developing age, the age of developing, right? Developmental age is actually the age when amblyopia will starts, right? So remember this thing, this is important point. So you need an early diagnosis. If diagnosis is earlier, you can treat, you can manage the amblyopia very easily, right? So for example, our age of the patient is less than 15 years and our patient is strabismus as well, right? So one eye of the patient is totally aligned, the central, and other eye is isotropic, and this is your beautiful nose between, right? So this is right eye, this is left eye, this is better eye, and this is, you can say, lazy eye or amblyopic eye. And you have diagnosed that patient is strabismic amblyopic. So squint is there and visual acuity is not improving without any structural abnormality, right? Then you will, after the visual acuity, you will get the RF values, right, in the both eyes. So this is better eye. So for example, this is better eye. So visual acuity is better in this eye. So RF readings are, for example, +1 here, right? And because this is lazy eye, so for example, this is supposed value, the visual acuity is less, so RF reading in the left eye is +4. These are RF reading, and after RF reading you will go for the cycloplegic refraction. This is important. You will instill the drops, you will instill the cycloplegic drugs in both eyes, right? And after instilling the cycloplegic drugs, the accommodation of the patient will be relaxed, and after that you will perform the retinoscopy, right? And the readings after the reading with cyclo are, for example, before cyclo the prescription in the right eye was +1, and now it will be, for example, +1.5, and in the left eye it will be +6, for example. So these are cycloplegic values, retinoscopic values after cycloplegia. So you see that before cycloplegia the values, the hyperopic values, the plus number is less, but after cycloplegia the plus number is more. Why? Because we have add the tonus allowance in this value, right? So now the plus number is greater because we have relaxed the accommodation. So now there are two different treatments in strabismic amblyopia. First is the optical treatment and second one is the treatment of patching, right? So first we will give you can say optical treatment. So this is our better eye, this is our lazy eye. So in better eye we need +1.5 and in lazy eye we need +6. These are values after cycloplegia, right? So remember that we will give the optical treatment, right? And we will make two different glasses. We will make two different glasses, right? And how? Why two different glasses? I will put a line in the center. This is glasses number 1. These are glasses number 2. So glasses number 1 is for routine, for every minute, and glasses number 2 are for therapy. So what will be the prescription in glasses number 1 and what will be the prescription in glasses number 2? So the glasses number 1 is for routine. So how much we will prescribe in the for the routine glasses for the every time usage? So you can see the prescription in the right eye is +1 and left eye is +6. So in the right eye we will prescribe +1.5, right? But if we prescribe +6 in the left eye, it will not be tolerated in the patient, right? So we have to reduce the prescription in the left eye, right? So we will prescribe a reduced prescription like +4 in the left eye. So this is for routine work. The patient, that amblyopic patient will wear these glasses every time, right? But therapy glasses, and these therapeutic glasses, the patient will wear these glasses for certain times, right? And in this glasses, the glasses number 2, we will prescribe the full correction in the both eyes. For example, we will prescribe in the right eye, we will prescribe 1.5 full correction, and in the left eye, we will prescribe +6 the full correction. And why? Because we are going to improve the vision in the amblyopic patient, right? So we will give a patch. This is called the optical treatment, right? And the next treatment is called the patching treatment. And how we will patch? Remember that in strabismic amblyopic patient, we will give alternate patching. Alternate patching. Why? Because when you will patch, you know very well that in strabismic amblyopia or in amblyopia, we always patch the better eye, right? We will patch the better eye and we will insist the lazy eye to see, right? So we will patch the better eye, right? And we'll make the patient to see with the lazy eye, right? And then remember that, keep it in mind one thing, that when we will patch this eye, right, that eye will fixate, and that fixation will lead towards better visual acuity. So as I have told you that we will perform the alternate patching. For few hours we will patch the better eye, and for few hours we will patch the lazy eye, right, to prevent the reverse amblyopia. So if we permanently occlude this eye, if suppose we occlude this eye for 4 years, for 6 years, then this eye can also get the amblyopia. So to prevent the amblyopia in the better eye, we will prescribe the alternate patch here, right? So in first week we will the patching hours will be 2 to 3 hours. In the second week the hours will be increased. Like in first week we can patch the eye 3 hours or 2 hours. In the next week we can go for 4 hours. In the next week we can go for the 6 hours full-time patching, right? But we will prescribe the alternate patching here, right? So again, so this is our better eye, this is our lazy eye. We have two different glasses. One glass is for routine work, for the every time use, and the prescription is least in the routine glasses, right? But the prescription in the therapeutic glasses is full correction, right? And when we will patch the better eye, then after patching the better eye, we will make the patients to wear the therapeutic glasses, the full correction, right? Because we need our patient to see with full correction, so his or her amblyopia can be better, or his or her vision can be better in the amblyopic eye. So finally, that's all about the strabismic amblyopia. In the next video, we will learn about the most interesting and most important another type of amblyopia, which is called the anisometropic amblyopia.